So my name is Nicholas Thiessen, and we're going to be talking about steroids in trauma and critical care. I have no disclosures except for the fact that I changed my talk. So really I'm going to talk about 4 papers, and at the end I'm kind of going to bring it all together and go over steroids in a little bit more detail. When I say steroids, I'm talking about glucocorticoids, specifically cortisol. I'm not talking about like roid rage steroids, like the anabolic steroids, but I did type that in as like steroid memes, and I put a lot of pictures in my talk because I thought they were kind of funny. But we are talking about cortisol itself. Just to give you an idea, cortisol was the physicians who discovered it in the 1950s and won the Nobel Prize for it. And it was highly prescribed in the 1950s to treat anti-inflammatory diseases and processes. It was very, very popular in the 1950s to be prescribed cortisol. And there's actually a movie called Bigger Than Life. I highly recommend going to YouTube and typing in Bigger Than Life movie and look at the trailer. It's absolutely hilarious. NSAIDs came out around the same time, and they actually got their name, NSAIDs, non-steroidal anti-inflammatory drugs, to differentiate them from cortisol and all the side effects that cortisol had. And Bigger Than Life, the movie, goes into all those different side effects. So one of the first papers I wanted to talk about was the Corticus Trial. This is probably one of the most popular trials, or the biggest trials to come out in the last 10 years regarding steroids in critical care. This is in the New England Journal of Medicine 2008. And what they looked at was, it was a multi-institutional, double-blind, randomized control trial, placebo-controlled, very well done, 500 patients, 250 basically in each arm. And half of them got hydrocortisone, the other half didn't. These patients were in septic shock, and then they looked at outcomes. There was no survival benefit in the patients that received the steroids. They did, however, the patients that received the steroids recovered from their septic shock sooner, but didn't have any survival benefit. And there was a trend for worsening infections, superinfections, worsening sepsis, and worsening septic shock in the patients that did receive steroids. Because of this trial and the surviving sepsis guidelines, we really only use steroids in refractory shock, in patients that are in septic shock with refractory shock. 9 days ago, this paper came out in JAMA. It's the Hypress trial. All these have really cool names, by the way. This was the effect of hydrocortisone in the development of shock in patients that were already in severe sepsis. So the Corticus trial was looking at patients already in septic shock and then randomized controlling them. These patients had severe sepsis, and then they were randomized. And basically, what did it show? It showed that corticosteroids did not improve any important measures. They still went into the same amount of shock, whether they received the steroids or didn't receive the steroids. There was no mortality benefit between the two. Both of them died at the same rate. Now, the numbers in this were really, really low. I think there was only, I want to say there's 50 in each group, roughly. And the trends numerically was that the patients that received the steroids had a higher chance of dying and higher chance of infections, but it was very, very underpowered to make those determinations at the end of the paper. Now, those were critical care. Those are 2 articles from basically critical care. But what about trauma? So this is just Lance Armstrong saying he never doped. So another cool name, right? Hypolite, hydrocortisone polytraumatis trial. So this is a French study. It came out in JAMA 2011. And so this paper was really looking at trauma patients and then trying to see if they could affect or have any modulation on hospital-acquired pneumonia or ventilator-associated pneumonia. And this is also a multi-institutional, double-blind, randomized, placebo-controlled trial, very well done. And what it did show actually in these patients that there was a reduction in hospital-acquired pneumonia at 28 days. There was a decreased requirement for ventilation and a decreased ICU length of stay. It was a pretty well done paper. And the next one doesn't have a cool name, which I'm kind of sad about, but this is our fellows out of Shock Trauma. This is the Journal of Trauma 2013. And what they looked at was the hyperacute adrenal insufficiency. I think they call it like HAI. They had kind of a cool little abbreviation for it. But what they did is they looked at patients that presented to their trauma center hypotensive and bleeding, so in hemorrhagic shock. And then they just drew cortisol levels from them and then followed them to see what would happen, right? And the patients that had cortisol levels less than 10 had a significantly higher rate of dying from their hemorrhagic shock in the first 24, 48 hours, and or just in-hospital mortality rate. But that paper didn't give steroids, they just were checking cortisol. So the reason why I wanted to talk about those 4 papers is that I think a lot of times in our literature, especially as a surgical critical care surgeon and someone who runs ICU, is that sometimes we blend the two together. And I think when it comes to steroids, we may need to actually pull them apart. We have surviving sepsis guidelines, and we have a lot of data regarding steroids in septic shock patients, but trauma patients may be a completely different beast. And we may need more randomized controlled trials, multi-institutional trials, to really delineate these two to see who may benefit from them. And as I was sitting back there, I was thinking, man, what would be a cool name for like another steroid trial? And actually, it's right here, right? So we have Southwest Trauma Acute Care Steroid Trial, right? If everyone of the level 1 trauma centers that are here got together and said, you know, what if we came up with a protocol, who to look at, who to give steroids to in trauma patients, not in septic patients? Could we come up with our own guidelines in these patients? Just something to think about. Thank you.